Now, for our third speaker, Dr. Giovanni Volpicelli. He's an emergency physician from San Luigi Gonzaga University in Italy. He's a fellow of the American College of Chest Physicians and a member of the American College of Emergency Physicians. He has a great interest in ultrasonography and critical care, and he was the chair of the scientific committee of the first International Consensus Conference on Lung Ultrasound. He's also a member of the scientific committee of the second International Consensus Conference on Ultrasound and Trauma. He's a member of the board of directors of the World Interactive Network focused on critical ultrasound, and also the director of the Lung Ultrasound Group, and actively coordinating the international program of education on ultrasounds. He's editor-in-chief of the Critical Ultrasound Journal and member of the editorial board or reviewer of many international journals, including the New England Journal for Medicine, American Journal of Respiratory and Critical Care Medicine, and American Journal of Emergency Medicine. I would like to welcome him and ask him to present his lecture, which is Clarity in Darkness, Use of Ultrasound in Perioperative and Critical Care Medicine. Thank you.
Thank you. Thank you for the presentation, and of course, thank you for this very kind invitation to Kuwait. This is my first time in Kuwait. The topic, the board assigned to me is quite wide, because use of ultrasound means use of multi-organ ultrasound. So, but because I have only 20 minutes to speak, and because my main interest in research is lung ultrasound, I will only speak about lung ultrasound, and also because other presenter before me spoke already about cardiac ultrasound. What is lung ultrasound? It is possible to define lung ultrasound in a very few words. And these new words describing lung ultrasound came in the last, I would say, 15 years, no more. Because before these 15 years, the last 15 years, ultrasound was considered not useful to study the chest diseases, because, you know, air is inside the lung, and air is the enemy of ultrasound for physics reason. But now we know that we can use ultrasound to make a differentiation between these three main patterns that are showed in this slide. First, it is not true that it is not possible to see the lung. As you can see in this pattern here, we can see a perfect image of the lung. And this is because in this lung there is no more air inside. Whereas when we have a normal balance between air and fluid inside the lung, then of course we only see artifacts. And there is a pattern that is in the middle, where you have less air than normal, but not totally lost from the lung. That is the interstitial syndrome that is in the middle. So the modern era of lung ultrasound is the interpretation and the application at bedside of these three basic, very basic patterns that any one of you can see just by putting the probe on the chest wall of your patients. Lung ultrasound, in a very simple words, is just a densitometer of the lung. So we can use ultrasound to measure the density of the organ. And ultrasound is sensitive to variation in the balance between air and fluid in the lung when air is lost from the lung. That is perfect, because most of our patients have this problem in the ICU and especially in emergency situations. And this is just very well, in my opinion, displayed in this screen. So we have a wonderful tool to measure the density of the lung. This is wonderful, but of course, this is also a rough methodology. No one can say what is the disease of the patient by only using ultrasound. We can only say, okay, the lung is more dense than normal. The lung is losing air. But we cannot say if this is due to cardiogenic edema, for example, or ARDS, pneumonia, atelectasis, and so on. So we have a wonderful method to measure the density, but not enough specific. So it is a very rough methodology. In this slide, we have a situation of pneumonia where we have, in the same area, in the same lung, two different parts of the lung with different density. So this is the demonstration that we can use ultrasound to measure a different density in the lung tissue. A consolidation on this side and the interstitial syndrome on the other side. So this means that here there is more air than in the consolidated lung. Simple. And we can even use this power monitoring patients. Because, for example, this patient had an atelectasis due to obstruction because of a thrombus in the airways after a trauma. And just removing the thrombus by bronchoscopy, what we observe in a few seconds is the change in aeration of the lung, going from the atelectasis to the interstitial pattern. Perfect. It is really very powerful. But still, don't forget that it is a very rough methodology. Indeed, I will show you, and you know, we have two different mechanisms of increasing density. Lose lung deflation and increasing fluids. But it doesn't matter for lung ultrasound. We can observe increasing density. Any mechanism is the cause of this increase in density. And this is the sentence coming from the statement coming from the consensus conference in lung ultrasound, saying that we can use this tool to follow the change in aeration, in lung aeration, following these four main patterns. You must consider that these two in the middle are a variation of the same interstitial pattern, more or less deaerated. So, in our patients, we can follow a situation of loss of air, or we can follow also the increase in aeration, so recruitment. So we have a rough methodology, but I will just focus on some new application of lung ultrasound that will show you that this rough methodology can allow us to make very advanced application in critically ill patients, very complicated patients who are the patients we care about in our daily work. So we can assess pulmonary aeration, and we can use a score, a simple score, studying 12 areas, 6 areas per side, 2 anterior, 2 lateral, and 2 dorsal. And then we combine all these areas, giving to each area a score based on the patterns I showed you, from 0 to 3. And then we combine all the areas, and we have a full score of the patient, giving to us an indication of the kind of the degree of aeration of the lung of the patient. And then we can use this information, putting into our software, following up the patient during days and during hours, during our the hospital stay, of course, like this group did in this slide. We can monitor alveolar recruitment, and this was shown in this wonderful study published in the Blue Journal by the French group. And we can give to each improvement of each area a score following this reaeration lung ultrasound score that I show you here. And we can compare, of course, this change after a treatment, or even we can compare reaeration score in each area of the lung, because you know we have the problem to assess regional change in our lung, in the lung of the patient. And this was in agreement with the pressure volume curve methodology that was used as a standard reference. We can monitor pulmonary congestion in the cardiology setting, for example. And this is the first paper showing this power of lung ultrasound in acute decompensated heart failure patients admitted to the hospital, just observing the change in each area of the B-line score. B-lines are the sign of interstitial syndrome. We can follow up the change and the improvement of our patient when we give the treatment of these on these kind of patients we have. Another very advanced application is the hemodynamic assessment that we can use lung ultrasound to improve the assessment, the hemodynamic assessment in our patients. There was this paper that was first published in 2009 by the group of Daniel Lichtenstein, and what he found in the ICU patients was that with absence of B-lines in the lung, the A pattern, this corresponded almost always to low levels of wedge pressure. And this was in a group of patients in only one center. Great. But I think the correlation with the wedge pressure is not so linear with pulmonary congestion. So B-lines means pulmonary congestion. And this was not confirmed in another study that we did, in a multi-center study with many more patients. What we found was that this correlation was not true, because we observed many patients with very high level of wedge pressure, but not pulmonary congestion. Whereas this correlation was much better using the extravascular lung water assessment by the PICO system. What is the meaning of this finding? It is very important, in my opinion. The contribution of lung ultrasound is to provide direct insight into the pulmonary interstitium and detect conditions of fluid accumulation in the pulmonary bed. Whereas the wedge pressure identifies hemodynamic overload that not necessarily is linked to pulmonary congestion. And lung ultrasound is a wonderful methodology to differentiate these two kinds of patients. So we have hemodynamic congestion and pulmonary congestion. They are separated. And why this happens? It is very simple, because pulmonary congestion is a matter of pulmonary pressure, but also permeability in the capillary bed. So you can have situations where you have high pulmonary pressure, hemodynamic congestion, but low permeability.
5 minutes.
Who are these patients? They are the chronic patients, probably, with heart failure, chronic heart failure. Whereas we can have high pressure and normal permeability. In this case, you have pulmonary edema, cardiogenic pulmonary edema. Or you may have normal pressure and high permeability, ARDS, the pulmonary edema in ARDS, for example. So lung ultrasound can differentiate these two situations, can assess lung tolerance to fluid. No B-lines, you can give fluid to the patient, and can assess congestion. And then, of course, by monitoring and observing the change during fluid treatment, you can see when B-lines, the early signs of congestion appear in your patients. And finally, the last very advanced application is the study of anesthesia-induced atelectasis. You know that this is a problem in our patients, not only in adult patients, but also in pediatric patients. The numbers are very high. And this is the example of what happens in our patients, examples of anesthesia-induced atelectasis. So what is the potential of lung ultrasound? The potential is that lung ultrasound is more sensitive than chest radiography, for example, and not so sensitive, of course, like CAT scan, but we cannot use CAT scan in our patients. So the only way we have to assess this kind of conditions in the lung during the operative scenarios is to use lung ultrasound. And not only to use lung ultrasound to assess the condition of the patient, but also to assess the change that we can obtain by changing our ventilatory strategy. This is an example of what happens in tidal recruitment and after recruitment maneuvers. So we can assess the difference in a stable recruitment obtained by maneuvers. So what we can do is to change our ventilatory strategy to obtain recruitment, and then the same to titrate the correct ventilatory strategy to obtain the minimum level of recruitment that is the safest level for our patients.
2 minutes.
Thank you for your attention.